Good morning, everybody, or good afternoon, or hello, everybody. Today we have Dr. Rowan Hearn. Dr. Hearn is the Clinical Director of Palliative Medicine at Calvary Healthcare. Rowan supports the improvement and quality and safety in palliative care, having served as a member of the Governance Committee for the Palliative Care Clinical Network, that's difficult to say wrong, for the Department of Health, and co-chair for the network's expert working group for care of the dying person. Rowan is active in research into neuropalliative care and telehealth, with further research interest in carer support. Prior to working at Calvary, Dr. Hearn spent 15 years working in the National Health Service in London, whoa baby, during which time he completed his Masters in Medical Ethics and Law and was lead for clinical governance for his service. Wow, you've crammed a little bit into your life there, mate.
A little.
How are you? Thank you for being here.
I'm very well. Thank you very much for having me. I'm really looking forward to our conversation today.
Yeah, extremely important conversation. So, Rowan, as you know, we like to know who you are, not what you do. So, who's Rowan Hearn?
Who am I? Well, I guess it's difficult not to say doctor up front because that's a big part, I think, of who I am. But I'm also a son, a brother, a chicken breeder, something random out there. So, yeah, I think family's important for me. It's the main reason actually I came back from the UK a few years ago was to spend more time with my parents as they were getting older. And part of that was actually taking on a carer's role when my mother experienced dementia before she passed away. So, for me, as a carer, it becomes part of who you are, really, doesn't it?
Yeah, once you've cared, that's it. It's part of your DNA.
Yeah, it's interesting, and that's actually helped me professionally as well because that gave me a new insight, I think, into the carers and family members I was dealing with professionally, really.
I think that is often the missing chip when you're dealing with medical professionals, in that they've never been where you are, and so that I'm going to say chip is missing.
Yeah, I completely agree. And I think you can see it amongst healthcare professionals more generally, those who have had a caring role and those who haven't. And I can only speak from my experience, but I think definitely there's a change in my professional behaviour once that.
One on or a negative one?
Positive. I hope positive. I think you're right. The experience in the UK and the National Health Service, it's great to get a different perspective. They've got a really strong focus on patient-centered care.
Yeah.
And that's, as you said, something I'm really interested in, the governance and the quality and safety and looking at how we can improve end-of-life care generally. Yeah.
Okay, so I think before we get to that point, we should go back to tours and for you to tell us, what is palliative care?
Well, for me, palliative care is a lot about looking at how someone can live well now. Everyone gets quite focused on an end point.
Correct.
So much leading up to that end point. And for me, I think there's also an element of trying to give back control.
Yes.
People who are experiencing a palliative care diagnosis, they're just told, you have to do this, you have to go to that clinic, you have to try this medicine, you have to have this chemotherapy. And so there's a bit of a loss of control.
Very much a loss of control.
And if what we can do in palliative care is give back a degree or a sense of control to the patient and their family, then I think that's a really important part. And so that control can be really simple things like a choice in medications. Or for one patient, I remember the control was the time of day they were going to come into the inpatient palliative care unit. It sounds like a small thing, or where someone wants to be. Do they want to be at home? Do they want to be in hospital? Do they want to be in a residential aged care facility? So control, I think, is different things to different people. But for me, control is a really important part of palliative care.
Let's take it even back one step as well. What actually is palliative care?
So historically, people would sort of look and say, oh, it's just care in the last days of life. It's all very much around death and dying. And I think historically, yeah, maybe 20, 30, 40, 50, 60 years ago, sure. But we learned a lot of skills. We learned a lot of things of managing symptoms, how to make dying better. And actually now we can use them to help make living better. And I think in this day and age, a lot of conditions, there are great treatments for, some more so or less so than others. But many terminal illnesses have become chronic disease. And actually, not uncommon, I've treated people who have years of life left, 8 years, 6 years, 10 years, 12 years of life ahead of them. I've been lucky enough to use some of the skills from end of life care to help people get through curative treatment. So that's, there's this developing awareness of supportive care, which is to help people, to support people to live well, regardless of where they are on their disease trajectory. I've met many people just at the times they're diagnosed with the disease, they're nowhere near dying. They haven't even begun treatment. They've got years ahead of them. But there are things we can do even at that stage to help improve the quality of life and help them live better. And it's not always just about a tablet or a medicine. Is it information needs? Is it education around care? Is it equipment? Is it how to access support services, psychological support? There's so much to it. People get quite focused on just a medicine or something at the end of life. And I think for me, palliative care, I was really drawn to it many, many years ago.
Why?
It's so holistic and it's so challenging. So it's never just about the patient, because very few people live in isolation. So there's a family unit, a caring group, family and friends who need support and have information requirements and education needs as well. And it's always complicated, because we're humans with complicated things. Yeah. And so one person might have a complex pain that needs managing, whereas this person actually there's challenging family dynamics and conflict within the family, or this person has some distressing psychological question that they're pondering. So there's a complexity to palliative care that comes through in everyone, and everyone is different. And so one of the things I like professionally about palliative care is that it's very holistic, and it involves not just the patient in front of you, but their whole family caring unit as well. And there's so much to it.
You just reminded me of a story. I used to volunteer in Palliative Care in Sydney, and there was one particular family that the sides hated each other with a passion. And managing them coming in to visit was military precision. And it was agony. And then we had another couple. It was a mother and daughter who were in Palliative Care at the same time. And again, the family members didn't like each other. So
Conflicted families, and you never know what happened leading up to someone entering palliative care, and it's not our place to try to fix fractured families. You can't. To think we could would be a bit foolish, but we have to meet the care needs, the needs of all the different people. So I think palliative care has certainly evolved from the historical bit of just end of life care, when it was all just about, increasing the pain incidence and keeping the family happy. It's much more nuanced. There are many more interventions. There's more support. There's more we can do early on. And I think very much supporting people to live well is a really key part of palliative care in this day and age.
You and I have discussed privately that I think that palliative care has a branding issue.
Yep.
Because the instant one says palliative, people think of death and dying.
Yeah, absolutely.
Whereas you've mentioned, it's about symptom management, it's about care, and it's about living the best life you have whilst you have it. And I've mentioned this many times. The day after my husband was diagnosed, I called in Palliative Care. because I understood the benefit that they would have to him and to me as the carer and to his quality of life. And it was outstanding and made that awful journey much, much better. You used the words earlier, supportive care, which to me sounds like a new bra label, but we can work something out.
Yeah. It's interesting. This was a huge topic in the UK when I was there 10 years ago. And suddenly enhanced supportive care and supported care units started popping up around the country. And indeed, if you look at a lot of the services, health services around Australia, you'll see palliative and supportive care.
Yeah, well, that's palliative and supportive care. Enhanced supportive care really does sound like a jockstrap. I'm sorry.
Yeah, it really does when you say it like that. I should say I'm the clinical director of palliative care, not jockstraps.
Nice. I'm glad we cleared all of that up. Okay. So we know my story. Know that when I ask my community of people with MND, who have you accessed palliative care? The answer is, I would say 96% of the time, no. No. Because there's a fear, because there is an acknowledgement of dying. When do you think people should access palliative care?
I think, and we've recently started calling for timely access, rather than, so it's interesting, we're just starting to change from early access to timely access. And I think what that acknowledges is that it's different for each person. And it's really interesting because this tips into a little bit what makes a good death. And for some people, a good death is this calm acceptance of their impending death with all the family in attendance and no unnecessary interventions and sort of heavenly choirs singing, and it's all peaceful. That's fine for them. For other people, a good death is actually kicking and screaming in the intensive care unit, saying, I want more tubes, I need more interventions, I will not die. Yeah. And it's very important for that person to fight that fight to the very end and say no to this and no to that, I want more interventions. And that's okay. And I think that's because that second person probably doesn't want a bar of palliative care. Yeah. So I think it's really important, the idea of timely access, so that when that person and their family is ready. Now, that's not to say that we shouldn't encourage some gentle prodding. I think, because I agree with you, I think there are benefits to palliative care. So I think we need to make sure it's offered and that the benefits are explained in an early manner. And we can't force people to accept it, but I think we should make it really clear what the benefits are. I mean, for me, my heart sinks a little bit when I am referred someone at the late, when I'm referred someone at the very end, and everyone, it's all fraught. The situation feels out of control. There are not really that many options left. And I don't know this person in front of me. And is this someone for whom comfort and being pain-free is the most important thing? Or is it someone for whom being awake and alert and being able to see their children to the end is very important? Is it someone who has religious or cultural beliefs for whom it's really important not to have these interventions or medicines? Yeah. And to get that person at the end, when I can't understand more about them, yeah, that's really challenging. And that doesn't, that's where things can end up being less satisfactory than otherwise. Because if I've met someone early on, if our community palliative care teams or our clinics have met people really early on and their families, we get to understand what's important. Who are you? The question you asked me at the very start of this, who are you? What's important to you? What are your values and your preferences? And really importantly, these things change. Oh, information requirements change, don't they, as well? You don't want to be overloaded. Well, some people want all the information up front and they want it now when a diagnosis hits them. Other people are still trying to process and they say, no, I don't want any information, but they change their mind down the track. And if you've not got that longer relationship with someone, you can't meet their changing needs as well.
And, I think I've said this many times privately, is that picture of death that you had before, of the angels singing and in the bed surrounded by the family. People are people. So you've got to be realistic about the type of person that you have as well.
Mm.
If they're a crotchety old crotcher in life, they're going to be a crotchety old crotcher as they go towards death. If they're peace-loving mung beans, so it totally depends on the person. I think often people think that in that last week of dying, it's all peace and serenity. It ain't, baby, if you don't want it to be.
Yeah. It's interesting. A patient who I knew very well, and I looked after her for the last about 4 years of her life, and for 3 years and 11 months, she was really able-bodied and working in a high-pressured business job. And it was just the last few weeks where there was a big change. And I saw her for a particular symptom. And this comes back to the control bit. She had no control over what's happening with her disease, but she had control over the pain medicines. She wouldn't take them.
Ah.
And she'd come back to clinic and say, this pain is here. And we'd talk through it again. We'd say, does this medicine help when you take it? Yes. Do you have any problems when you take the medicine? No. Could you take some of the medicine now in clinic and we can just check it helps? And she would, and it did. So should we, there's once her father actually came in with her to clinic, and he was quite angry with me, saying, why aren't you helping my daughter's pain? And I just went through the same questions with his daughter, and he could see, and it was her choice. It was her choice. This was her choice with these medicines to take them on it. She had to take the chemotherapy. She had to go to the clinic appointments for the chemotherapy. And so she had no choice, she felt there. And I do see it sometimes where people choose how they want to manage their pain or a particular symptom. There's one patient with motor neuron disease I can think of recently, and he got sick and tired of being told he should do this, he should do that. And he was having some trouble swallowing. And the dietitian had suggested ways of modifying his food. He basically went, bugger that. I'll do it. I'll do it my way. And go for it. Not a problem. He's fully able to make his own decisions about things. And it was about control and what he wanted to do it his way. And that, I think for me, that's a really important part of palliative care. And if someone doesn't want to take the medicine I prescribe for them, that's fine. I've got to come up with a different plan. That's my job. If they say, no, I don't like this option. Okay, let me go back to the drawing board and see what else we can come up with.
Especially with MND, we lose control over everything, predominantly, except for our brains mainly. And so it is vitally important that we feel that we have control over our living and our end of life. And you're facilitating that.
Yeah, I think so. We call them, I'm sure you've mentioned this before, the advanced care planning.
Yes.
This is so important. I don't, look, this is me being lazy. I don't have to make decisions for someone else. I want you to tell me what you want, and then I have to try to make that happen. So if someone's been able to tell me what they want in the future, and look, no one's got a crystal ball. We can't guess everything that's going to happen. But we try to look in palliative care at different possibilities in the future. Particularly with MND, we know that there's going to be these changes that happen in the future. We can predict much more so than I think in other palliative diagnoses. And so there's a need to get ahead and be prepared for changes as they happen. This could be really confronting. I'm saying this more for people watching, not you know this. It's constant just this barrage. It's one change, then another change. You just adapt to one change, and the next thing happens. But having someone have a conversation before those changes start happening, because no one wants to consider what life is going to be like down the track with these changes. But I'm afraid we do still see people who say, "Oh, okay, I'm ready for this intervention now," and we say, "Oh, well, it's a little bit too late. We talked about this earlier, but I didn't need it earlier." Yes, but I agreed, but you're too weak for it now. Yeah.
Advanced care planning. So explain why that is so important to have.
So advanced care planning is really, really important. And there's different types of advanced care planning. The most basic advanced care planning is someone having a conversation with their treating team, with their neurologist, or their palliative care team, with family involved. That's a really key thing, to have family hear the conversation and saying, if I end up in this situation, this is what I want. If I can't breathe properly and ventilation is an option, I would like that. If I can't swallow properly and a feeding tube is an option, I do not want that. To say, and I think this is really important, because sometimes, I guess to take it to the real pointy end, if someone says, if I get a chest infection and I can't breathe properly because of a chest infection, I do not want to go to an intensive care unit. I do not want a tube down my throat to breathe for me, because that's not who I am. There's usually a lengthier discussion around that. Now, if that's someone's wishes and it's written down and it's signed through a process, it's a legally binding medical decision. It's immediate. You can refuse treatment. Now, that's so important, because without that sort of definite description, that definite decision, I'm afraid to say that my colleagues, the doctors and nurses in an intensive care unit, they have to err on the side of preserving life. And this is the bit that's really annoying. They can see the picture. They can see this is someone with end-stage motor neuron disease, perhaps, or an end-stage diagnosis. They don't want to put this person through an intensive care unit admission that they're not going to survive from. They don't want to do that. But they're faced with a situation where they don't know this person, they don't know the family, and they have to make snap decisions, and they have to err on the side of preserving life. I hate to say it, but I'm guilty of that in my professional career as well, because we've accepted a patient late, we haven't had a chance to get to know them properly, and we have to err on the side of preserving life, except except where things are bummed or obvious that someone's actually dying. And then it can be really horrible to then hear that wasn't what they wanted. And that written advanced care plan can happen.
Especially when a crisis hits, when a health crisis, and that paperwork has to be available too. So if you have it stuck on the fridge as well, I used to have a photo. I took a photo of it. It was on my phone. So when we went to the hospital, I had that available. But if the main carer is away for the day or popping out and there's a crisis, you need to have access to that advanced care plan.
It's very common it's very common. Someone will be in hospital for a week or two, and they say, "Oh yeah, we'll talk to them about advanced care planning," and say, "Oh yes, we've done one of these." "Oh really? Where is it?" "Oh, my lawyer has it." Or my GP has it. Oh, that's great that they've got a copy, but it's not a single copy. You want lots of copies. You want a copy for everyone.
I had them on the phone, on the fridge.
Yeah.
He was going out with someone. Yeah, just spread it around. So that's something that's also extremely important. Sorry, my phone just closed. Yeah. So can you explain? We talked about this a little before. Palliative care services, how are they offered specifically in Victoria, because we are in Victoria?
So we discussed this because there's variation in what community palliative care services are available in different parts of the state in Victoria. Um, and, as so many of these things, a lot of it comes down to funding. There's a set amount of funding for different areas. And there's local services have an ability to try to address the needs of their local population, which is very well and good, but they've got a limited resource to do that with. And so different services decide there are different priorities. So, for instance, there'll be one community palliative care service who's decided that they want to be able to provide nurses to go out and visit patients at home 24 hours a day if they need to. But that means there's less funding available for other things. So I know another service that doesn't have overnight visiting, but they have family support workers. So a larger body of staff who can potentially see more patients and their families and provide more support than perhaps the first service. So which one is better? And the idea is that they're both good. They've both got different focuses on what their local community needs. And so, for instance, I know another service that has decreased their allied health support of occupational therapy and physiotherapy because they have good local community services, non-palliative, in occupational therapy and physiotherapy. So they didn't want to double up. So, but that means that those services then aren't accessed through the community palliative care service. So another service will have a diversional therapist and music therapists, whereas another one will decide that they want extra physiotherapist or more nursing. So there's the challenge that we have in the community palliative care services is that there is variation from one service to the next, and that makes it tricky to be able to say this is what you should be able to get from your local community palliative.
Should there be a protocol of palliative care?
There's service specification. I know. Think so. Yes, I mean, they're you've asked a very good question. Should there be a service specification for what? Yes, and I think there should be a service specification of what a community palliative care service is. That's not a question I'm able to answer, and I think that's one that would be a good question for the Department of Health.
Okay, leave that one with me. People in this day and age are still afraid of talking about death. Do you find that when people come to you?
I find that, and we do. I do love it when we get some very vocal, health literate people who come in and want to talk about death. That's wonderful. That makes my job easier. But it's commonly the opposite, where people are scared and anxious, and there can be some particular things that people are particularly scared of talking about, or when I raise things they don't want to talk about, and it's tricky. I've had some people say, look, I'm very upset by this discussion, but it's important and I need to have it. So let's keep going. And patients have a right all the time to say, no, I don't want to discuss this. I only want good news. So that's a common one. And that's absolutely fine. Families, I'm afraid, don't often get that same, that they're not, they can't as easily say, I don't want to hear any bad news. So we've got to have these discussions. The patient can say no, but carers and families often have to have those painful discussions or difficult, challenging discussions. There's a purpose to them. We're not trying to just cause upset and distress. We have a purpose that we want to try to make the time ahead as less painful as possible.
Psychologically and physically.
Exactly.
So people are of the belief that MND isn't painful. Well, in instances, it is painful. I know people who suffer from a lot of pain from MND, and if you're out there listening and you're in pain, Rowan and his colleagues can help you with that so that you can live a better day, you can sleep better at night, and you can have, I don't want to use the word quality, but better quality time.
Yeah.
Your family and friends.
maximize the quality.
There you
Yeah.
go.
Yeah.
Session run.
I think you're right. I think people need to say, this isn't quite good enough, the situation I'm in. I need a better solution. And if the solution that's being put to you is what's unacceptable for these reasons, explain what those reasons are. And the team looking after you should say, well, yes, we can have a plan B, or they might say, oh, I'm afraid this is the only option, but these are other things we can do, or this is how we can mitigate. So a common one, and pain. So if people are less able to move around and they're losing body weight, and they do get pain, and there's pain from the motor neuron disease itself sometimes. And one of the tricky bits I face is the fear when I suggest a small dose of morphine. And we use it for lots of different things. People are like, oh, that means I'm dying. It's like, well, hang on a minute. So morphine is a medication. If I broke my leg in a car accident, the ambulance crew would give me an injection of 5 to 10 milligrams of morphine. If I had a heart attack and had chest pain, the doctor in the emergency department would give me an injection of morphine. So morphine is a medicine. And if I broke my leg in a car accident or I had a heart attack, I'm very much hoping that I'm not just about to die. So having morphine itself doesn't mean you're about to die.
Right.
We use morphine not just for pain, but we also use very small doses to relieve a sensation of breathlessness. So this is where it comes down to what you were saying about, and I agree, palliative care is about living well. If someone's experiencing breathlessness, which they can do with MND, or aches and pains, then small doses of morphine can help. And I commonly get people being anxious about it, saying, oh, I don't become addicted. What do you mean when you say addicted? Oh, I don't want to have to keep taking that for the rest of my life.
Well, why not?
Exactly. Now, if I had, and I say, look, if you've got other medicines, you take blood pressure medicine every day. Someone with diabetes might take insulin every day. People take cholesterol lowering medication every day. So just because you're taking it every day doesn't mean that you're addicted. And actually, if it's helping you live better with less breathlessness and less pain, surely that's a good thing.
Yeah, as I mentioned to you, I would sneak morphine. Well, he knew it was happening, but for instance, if Robert was going to have a shower, so that would exhaust him. And part of the exhaustion was the breathlessness. So little of morphine was amazing. And it also took the distress away from him too, which is the most important thing.
So people that they think, well, morphine, it's a pain medicine. It helps with the sensation of breathlessness. So some people, it can help with anxiety a little bit. Every now and then someone can get a slight euphoria with it, which, what, I like, I don't, I've seen that like one in 1,000, 1 in 10,000 or something, it's really not, but, and some people say, oh, it's a side effect. People get very worried about side effects of medicines. Oh, they've got a side effect from this medicine and we should stop it. So, oh, no. If the medicine is helping, how do we reduce the side effects? And not all side effects are bad. I had a patient who used to hallucinate West End musicals with his morphine.
Oh, that is a really good one.
Is that a good one? And they look. This is hardly some all-encompassing hallucination. It was just a tiny. He knew they were hallucinations. He was not bothered by them. So not every side effect is a bad side effect. Yeah. The other fear that people have with morphine is about, so you've already gone through, that means I'm dying. Now it's just, no, it doesn't. You can take morphine for a problem. It doesn't mean that you're dying. Some people go around, oh, it might kill me if I take too much. It might cause me to die. And the answer to that is actually no. If you take the doses that you're prescribed in the manner we tell you to take it, it will not hasten your death in the slightest. And actually, they did look at it in the Netherlands when they first introduced euthanasia there many years ago as a euthanasia drug, and they discarded opioids, generally all the morphine type drugs, because they couldn't guarantee it would actually cause death. What's interesting with the morphine based drugs is if you take them for a bit of time, it does actually, your body develops a bit of a protective mechanism. It gets a bit used to the drug. And so, there can be situations where if you took a really massive dose and you'd never had it before, then, that can be a problem.
Well, it's the same as if you've never had heroin before.
But exactly. Exactly. Whereas if someone has taken small amounts of it for a while, and we only ever increase it in a stepwise fashion. So we'll increase it sort of 25% from what it was the day before, or 50% or 10%. So it's always increased if it's increased in relation to the dose before. And the body is in that way of titrating it up slowly if it's needed, then the body develops a little bit of a protective mechanism. It becomes used to the drug in a way, and it's less likely to cause any problems for things like breathing.
Well, listening to that, and just from my own experience, morphine is nothing to be scared about.
Not at all.
It's a helper, not a hinderer.
It's a helper, not a hinderer. People get very scared about the numbers as well. Oh, that's a big dose, and we might start with just 1 or 2 or 5 milligrams, and someone might end up on 30 milligrams a day. That's fine. 40. The most I've prescribed for a patient a day was 9,000 milligram equivalent in London. So when people talk to me about, I'm on a high dose of morphine, when they're talking about 80 or 90 or 100 or something, it's not quite yet. Yeah.
Diggity dog. They must have had a background in opioid use. That's the
They had a background in something years, yes, I would say.
Oh, Lord. The other benefit of palliative care is to support the family, because when you're a carer, all the focus is on the person, as it should be. But the carers are doing the caring, and caring is the hardest job in the world. And I found, for me personally, when my pal care team would come in, I could ask them questions about anything to do with the care of my husband, around symptom management, and that could have been around bowel movements, bladder control, or anything that is not directly related to his death, but about his symptom management. Number one. Number two, the psychological support, the physical support, the emotional support, the spiritual support that they gave me was out of this world. And that's something that I don't think people should dismiss as well. I know you get sick to death of people traipsing through the house. I get that. You've always got someone in the house. But often it's a service or a mechanical provider, i.e. an OT or speech or something, to your person. But the benefits of having someone who can talk to you for 5 minutes, 10 minutes, whatever. Also, I find that palliative care nurses are brutally honest. And if I can, and I did say to them, how much longer do you think we've got? And they will answer the question.
Yeah, I think you've just identified one of the important reasons for early contact with palliative care. So the nurses were quite brutal, or brutally honest, I should say.
Brutal, amazing.
Yeah. But you see, they'd got to know you. They got to know what you needed from that. So by that early contact, that relationship building, they've come to know what your communication style is, what your information requirements are, so that when you ask a question, they have developed an understanding of what they need to tell you to meet your needs.
Correct.
And I think that's you've just really demonstrated perfectly exactly the benefits of early palliative care, because your information needs as a carer and the way that you want to deliver the communication is going to be different from the patient.
Well, I didn't know, but I needed to know so that I could provide appropriate.
Yeah.
Yeah.
And I think the needs of the carer for different types and levels of information, different education around different caring aspects does change particularly through the MND journey, where the care needs just evolve and change as the disease progresses.
Whereas with our son, we had Pal Care come in every day with him, 21 cancer. I never asked the question because I didn't want to know the answer, but that was my personal choice at that point. How do we access palliative care through our GPs?
Well, you almost a little bit asked and answered. It's as simple as that. Going to the GP and saying you've reached this point in the disease journey, and you feel as a family that you'd like to access community palliative care, or even just have some contact with them. Now, a lot of community palliative care services are trying to move to needs based because of the limited resources we were talking about earlier. They'll look at the needs of the family unit, of the patient at that time. And I hope they'd welcome with opening arms, even if they did a first assessment, come in, introduction to the service, and then say, these are the needs we can help address at the moment. So a discussion with the GP for the GP to make a referral into the local community palliative care service.
So the benefits with the service that we received as well is in the beginning, they came out, did an intro. I didn't need them much in the beginning, but they did have a 24-hour helpline. And so some 2 o'clock in the morning when I didn't know what to do anymore, the benefit of being able to call them and they could help me over the phone.
I think that's a really key thing. And we have, we always have a number of patients who we don't need to go out and visit much, but that first assessment gives them access to that 24/7 telephone support. Yeah, definitely keep on.
Just support. Anything particular you want to say about, besides the fact that we need to have, what did you call it, standard service across the country for palliative?
Specifications. Yeah. This is what a community palliative care service should have. That's.
Well, you're working on it with the community of practice that we're both involved in, and Rob and I are both involved in a community of practice where it's not only people who provide, allied health who provide services to people with MNDs, people who have never met someone with MND, but there's the possibility that they will. And there's a lot of learning going on in the community through that. And that gives me hope.
I think we should have hope of things improving in this area. There's a lot of goodwill. There's a lot of interest. You could focus on sort of limited resources and stretched services, but I think there's opportunity to look at where someone can access support, and it might be, maybe part of this is about signposting in different communities where the different support can be accessed. As resources become a little bit tighter, but I think there are resources out there if we can engage with them and support people to see where they are.
If this is my personal opinion, but if we gave death the same support that we did birth,
Wow.
think about that, Rowan.
That would be amazing. That would be absolutely amazing.
Amazing. So full support to the person, to the family, to the community.
Yeah. Great idea.
We're all allowed to have dreams and wishes.
It's good to have dreams, and it's just preferably written down so that we can use them as advanced care plans.
Touche. Now, everybody, if you haven't done, I know people, I speak with them regularly and they say, oh, I've got to do that advanced care plan. Oh, I've got to do my will. Yeah, you actually really bloody have to do it.
Really do. Look, I think, and look, people need to not get scared that it's got to be a formal written document. I was visiting a couple of cousins, cousin and his wife last year, and we were talking about this because they had elderly parents, my uncle and aunt. And we discovered something new about their wife of 40 years, that she wanted a particular thing at end of life. And so I didn't know that. So, it doesn't need to be a formal written document. It can be a conversation over the dinner table, and
Well,
I
you
think
can access the paperwork online as well.
I think, there's so many resources you can access. So start with the conversation, start with the family conversation. Talking death is over lunch on Sunday, coffee, brunch on a weekend, whatever sort of family meal it is. And then go, okay, we've had the conversation. Maybe we should think about writing some of this down.
And this is not just for people who have an illness, this is for everybody.
Anyone. Yeah.
Okay. I'm very grateful to you. Your voice is so calming. If your voice was the last voice I heard, I would be happy and grateful.
Very kind of you to say, Jane. Thank you.
Absolute pleasure. I love working with you. I look forward very much to continue working with you. And I thank you for what you do, because it is so important.
Thank you, Jane. I've really appreciated this opportunity to speak to you and have this conversation. Thank you.